started. I'll tell you about me. Pull the chair out. So we didn't print the minutes because we're terrible people. Did we send out the minutes? Okay, so we need to send out the minutes from the last meeting. It would have been sent out to y'all if we did, but we failed to do that, so I will make sure they get sent out. Where's Anika? Can you send me the minutes and we'll make sure we send it out Matt this afternoon anyway so everybody can take a look at them. Okay. Let's go around and do introductions right quick. And for housekeeping for everybody that wasn't here before the bathrooms, and I think there's some soda machines straight through there. And I know it's very hot in here and I apologize for that. Hopefully we remember to wear layers today. And so I'm Kathy Nichols from the Division of Medical Assistance, and we'll go around, I guess, this way because there's a few new faces here today. So if you could just say who you're representing as well as your name, that'd be great.
I'm Lynn Norton Ramirez. I'm a parent.
Sherry Howell, I'm representing NCAR.
Curtis Bass, I'm here with the North Carolina Providers Association.
I'm Carol Ornitz. I'm representing the Brain Injury Association and the Brain Injury Advisory Council.
I'm Sandy Ellsworth. I'm with DMHDD SAS.
Want to go over here or behind?
Why don't you go around the table and then we'll come back.
I'm Beverly Moore, parent of a young adult with autism.
I'm Cindy Ellers. I work at East Carolina Behavioral Health, and I represent the North Carolina Council Community Program.
I'm Carrie Urban with the Autism Society of North Carolina.
I'm Mike Merrill with the Stakeholder Engagement Group.
I'm Ashley. I'm a parent.
Oh, you're going to be so hot. That's how you get down looking at you in that coat.
She's got layers.
Yeah.
I'm Marlon Wells. I work with the Exceptional Children's Assistance Center.
Matthew Potter, Client Advocate, Stakeholder Engagement Group, and Board of Directors of Centerpoint Human Services.
We'll go back.
Okay, I'm Gina Lemons. I'm representing Benchmarks today.
Hi, I'm Mary Short, and that's Katie. And I'm here representing mostly the severe and profound end of the of people on the waiver.
I'm Carol Donnan. I'm trying to move away from the camera.
I know, I'm trying to.
I work here at the Division of State-Operated Healthcare Facilities, and I work with the developmental centers.
You're all together, so it's not that close.
I'm Vivian Leon, and I'm also with State-Operated Healthcare Facilities.
I'm Anika Vaughn. I'm with DMA.
Sarah Potter, parent.
Beverly Bell, DMA.
Jesse Snyder, Smoky Mountain, LMA, MCO.
Janie Markham,
Cindy Norman, Partners Diable Health Management. I'm Mary Manor from Centerpoint.
I'm Kenneth Bossell from the Division of Medical Assistance.
Rachel Morrell from DMA.
Buzz King from the DHHS Office of Communications.
Maya Williams with DMHDD.
So I appreciate everybody's flexibility. Obviously, we didn't get the Brown building today, and this is a little more uncomfortable. But everybody's being very flexible, and we will get through this. It'll be good. Even my poor slideshow is crooked today. That's how bad off we are. I can't figure out how to make it.
The chairs are nicer.
The chairs are nicer, that's true. So there's your payoff. I had all kinds of books going on over there. I'm a social worker, not an architect. It was not happening. So basically, the bulk of our presentation today, Kenneth sent out the definitions to you earlier. Can you just introduce yourself, please, sir?
Fed Waterloo, Seals, Natural Policy.
And so I lost my train of thought. It's Friday and I'm blonde.
Sent out the slides.
Thank you. The entire agenda is going to be basically focused on some of the waiver definition group. And Andrea's not here. Is someone filling in for Andrea?
Well, Jamie and Jesse are. doing this right at this point.
Okay, so, and they're hiding back in the corner, but you'll see them when they come in and talk. Jesse Smathers and JD Markham from ECBH are here. Jesse's from Smoky Mountain Center, pardon me. And then I thought Andrea from Cardinal was coming, but maybe something happened.
Something may have come up, yeah.
I don't know, so they represent the waiver group,
Right.
the waiver definition group that we were kind of talking about before, and they're the ones that your definitions that we've been looking at are kind of getting filtered back to, correct?
Correct.
And hopefully we'll come back to you again with the input from their local stakeholder committees, so
They'll
we
talk
can
about that a lot in the presentation.
move towards some finalized definitions.
Correct.
Anything else you want to say there, Kenneth?
Ms. Short, actually, when I sent out the service definitions, I took it from our policy, 8P, and some of the service definitions in the waiver are a little bit different. Some information with a SNAP was added because the SIS wasn't statewide, things like that. So they're a little bit different, but for the most part, they're there.
Can I say something about that?
Sure.
It actually is from the technical guide, the manual, what you sent out, rather than from the October 1st, 2013 waiver document itself. And the 2013 waiver document itself is where the SNAP is not mentioned. And there's some other differences in the actual waiver.
I can go through and kind of highlight those, but I actually took it from my version of the policy 8P, which came from that, but
No, because 8P mirrors the 10/1/2013 waiver.
okay. Well, okay.
Yeah.
So
Sorry.
do you want to say anything about your speakers, or who's going to go first, or?
Jamie and Jesse were planning on doing this presentation with
Yeah.
Andrea. So
We were planning on Andrea doing the presentation for us. She left us out to dry. Something's come up probably because she had to move. So I'm Jesse Smathers, and I'm from Smoky Mountain LME MCO. We were Smoky Mountain Center, but now we're LME MCO, to clarify what we do, I suppose. And Jamie and I, Jamie, go ahead and introduce yourself.
And I'm Jamie Markham with East Carolina Behavioral Health.
And we are on the Infrastructure Service Definition Work Group. And we've been learning a lot as we go through this process because there's a different level of stakeholder engagement than any time that I've ever done this. That's for sure. And it's really kind of refreshing, to be honest. And we're coming to you today to do an overview of the waiver. I know you've seen some of the definitions that we've crafted, and some of them you liked, some you didn't. We're going to look at the waiver and touch on some of the things that it offers. And let's see, go to the next slide. How do I do that? Because
Oh, you're not in it at all.
there we go. And what we've done, we met November 10th.
It's not a good day for technology.
I live in the mountains.
You need to stand to
We
the
have
side,
problems.
too.
Where do
so
I
you
need to
still
stand?
do.
Oh,
No, not just.
I could go right through
You
the
didn't get it.
How about we
You gotta
stand
stay
in
like
that
this,
corner?
Jesse.
right over on this side.
No, I'm telling you how
You
to stand.
advance.
No, sideways, because that's sideways.
You need to
Can we
stand
just sit
sideways
down?
because it's crooked.
Yeah, feel like that, there you go.
It was better.
There we go.
No, it looks like the camera's off.
We met on November 10th, and we started this process way back
Too
in
funny.
June. And as we've moved forward, things have changed, and it's become clear to us how much more we need to involve stakeholders. So we met back in in November 10th, and we've established some different timelines that we're coming to you first to get feedback about the definitions. Then we're going to go back and write definitions, then bring the definitions back.
And in between there, we'll take it to the local stakeholder.
Right. We'll be involving all of our local stakeholder groups because all 9 LME MCOs have local stakeholder groups formed now. So there will be a lot of stakeholder feedback into this waiver. And our goal is to have some final draft definitions by the middle of March. Is that the accurate date, or did that get moved
well,
up?
we're going to present them, but we hope to have everything.
Yeah.
Final, and then it's ready to go on the waiver. They would come back here
Before the
right?
Right,
Okay.
yeah.
Yeah, then we're on the same timeline.
Okay. go to the next slide, please? The goals of the waiver.
So, I believe some of this information may have been covered last time, so I don't want to inundate you guys with information that you've already heard, but as you know, there are a variety of goals from the Innovations Waiver, and what we've done is we've taken a look at those, and we're trying to ensure that all of those are implemented into each of the service definitions that we review. So, just to kind of point out some of those, first and foremost, to value and support anybody who receives services, to ensure that they are fully functional within their environment, to ensure that they have a meaningful day of their choice, whatever that may mean to them. Obviously, to ensure the overall health, safety, and well-being of any individual who's receiving services, while at the same time trying to make sure that they are not solely reliant on a service system. Ensuring that they are integrated within their community through the utilization of services, and to ensure that whatever services are being implemented are of quality. So like I said, any service definition that we're looking, we are ensuring that all of the different goals of the waiver are fully implemented into each one of the service definitions. And as Jesse outlined, what we're doing is we're taking a look at each service definition, we're getting feedback from this stakeholder group, we're taking that information to the local stakeholders, piecing all of that information together, and then bringing it back here for a second review.
Yeah, and today, what we need from you, and like I say, we've stepped back to get this up front. We want to hear from you what you feel is working in the waiver, what's not working, what you feel is missing. We have 17 definitions in this waiver, and some observations was that maybe a lot of folks don't realize everything that's already in the waiver, because people tend to get pigeonholed into the services that they're receiving and not look beyond those. So our idea here was to just do an overview of all the 17 definitions, and we broke them into some categories, which we'll be touching on.
Now, did you guys, since you're at a transition place, but first of all, does anybody have any questions about anything so far? About the goals of the waiver, or what have you? Carrie had asked at one point in time, and I don't know if this ever got translated up to you guys, if you guys have like any kind of like a matrix of what those 17 definitions are and where they're at in the process.
That's what we're going to be presenting. We don't have a matrix of where each of them are in the process. We're getting closer to that. We do have a timeline of the groups that we want to look at in a certain route. I don't think that's in the actual PowerPoint.
Correct.
But we do have a timeline, which we can give you a rough estimate on.
Not to speak, she speaks for herself just fine, but I didn't know if that suggestion had made it to you that was something that they thought would be useful.
No, and we actually discussed that during our meeting, and we're trying to push up the timeframes a little bit, and we're still working on how to get that as accurate as we can.
Does that make sense, though?
We're close to being.
I think, there are people kind of like, what are we doing? We're talking about this definition, and then over here we're talking about this one. So I think your presentation today will be super helpful. But just
we're really taking a step back.
Right.
This is almost what we should have done to start with. Okay? But we're learning as we go. We really are, because of the expectations that we have to meet.
And we've actually developed a SharePoint as well, where that way we can save all of the information in one centralized location versus kind of going back and forth through emails, and the version that I respond to is not the version that Jesse responds to, and then information kind of gets crossed and lost and confused and so
wow,
forth. And
good.
within that database, we do, as Kenneth said, we do have a timeline of what to do and when. That timeline currently has us extending until the end of March. However, we do want to see what can we move around to have it be about 2 weeks prior to that.
The goals you just reviewed, did your committee determine those goals, or were they presented to you through the waiver? Are they the goals?
They're the goals that are written in the waiver document.
Yes, ma'am.
In the current waiver document?
In the current waiver document.
That's our current stuff.
And it's kind of the expectation of any waiver.
I just heard goals in another presentation, didn't see why this one.
Yeah, there's a five goal version. It's in the Innovations Technical Guide that summarizes the 10 that we shared.
And we summarize the 10 that we summarized. That's the confusion. Right. So any other questions?
question about the local stakeholders group. So at some point, if you can tell me who I can speak with about where I can find that information, that would be great.
Where you can find, what
Just-
information in particular?
Just how one could contact in a community members of the local stakeholders groups.
And I'm sure that's information that each individual NCO could probably, and
That's
each,
a good idea, that maybe we can collect that and put it on the state website.
Right.
That's what we're doing now,
Yeah.
because I've got multiple jobs going on here. Kenneth and Maya, that might be a good thing to post.
Okay. Like this, stakeholder?
I think that's it for now. Okay, moving on. So like Jesse said, we have divided the service definitions up into different kind of categories, and we group them together according to the categories that all of them kind of represent or are related to. So for instance, we have a category that we entitled living. And within this, we included any service definition that's kind of like an in-home service, residential services, the service of community transition, and respite. And the goal of all of these services is allowing the individual to choose where they live. Another grouping that we have are the crisis services, and within there's crisis supports, and the outcome, the expectation of these services are that I will be safe within my community. And then we have a grouping of services, of day services. So in here we have day support as well as support and employment. And this, and as I mentioned previously, ties back to one of the goals of the waiver, which is ensuring that I have a meaningful day and I can choose how I want to spend my day.
And then a few other categories is choosing what I do in my community. And right now, the services that allow us to do that are community guide and community networking. Self-direction, managing my own services. This is slowly rolling out throughout the state with regard to the agency with choice and employer of record programs. And some services that are attached to that are individual goods and services, and then of course financial supports, which allows an agency to pay for the employer of record services. In the waiver, there's education services. And we titled this Access to Supports for Growth. And this includes natural supports education, ways that we can help people learn about the folks that they're working with, and then specialized consultation where we can get some specialty services, some consultations from PTs, OTs, behavioral specialists, all sorts of different things to help the person stay in the community and be more involved in the community.
And then last but not least, we have a category of equipment. And this is to have the adaptive supports that I need to be able to live in the community. And under there, we have the 3 different service definitions of assistive technology, equipment and supplies, home modifications, and vehicle modifications. And what we'll do is we'll go through each one of the services into a little bit more detail. We just wanted to show you guys how we broke them up into different categories based on how they are kind of grouped or related to one another.
I get 16, what's missing?
Under in-home, and we'll get to that, there's currently multiple services under that, which is where they may not, if you count the individualized bullets, where it may not add up to 17. So.
And I may have misspoke. I can't do that.
Good answer,
so
Jesse.
This actually answers your question right here. Currently, within the current waiver, we have in-home skill building, personal care, and in-home intensive supports. These services are distinct from one another. They provide teaching and habilitation. They offer assistance, and they provide supervision. Now, I know some of these service definitions have already been reviewed and talked about by this committee. What you'll see on each one of our slides is we have kind of a current description, just an overarching description of the definition, and then we have what's been proposed. And what we have on each slide as far as what's been proposed is what has been proposed by y'all. Some of the slides you'll see where it says proposed is kind of like a to be determined. and that's simply just because you guys haven't reviewed that information yet. So based off of the feedback that we've got surrounding these three services is to actually combine these three services into one service definition. And that's something that this group is actively working on. The name of that service is currently proposed to be integrated supports, and it will actually enable or allow the individual to have a kind of more natural flow to their day.
Now, since this is your whole presentation, is good. I think it was good to see this group like that. I think it's great we're doing this, and you're right, Jess, you probably should have done this first day. What are you going to do? Live and learn from your mistakes, right? Do you want to take some time as we go through each one and kind of discuss them?
That was our goal with the paper. We need someone to write on the paper.
Kenneth does such a
That's
good
what we brought
job.
to other people.
And we do have two scribes over here. They're actively taking notes, and then what we figure we'll do is
Put the main points on the
right.
Yes, the main points. Because I know that integrated supports was brought to this group, and some people liked and some people didn't. That's, of course, what you always have when you work with something. The name is some things that I've heard people complain about in my local stakeholders group. So, what are some thoughts about the existing services and any ideas for combining the services?
I understand that it may have been 10 years ago or so that for at least 2 waivers, there was a similar combined service where it was a rate that combined what is now legal and personal care. Do you have any information on how that worked, whether it was successful, why it was changed? I think it may have been called daily support.
Home supports.
Home supports. Yeah, that was in the 2008 waiver and the 2008 waiver. It wasn't, and it was also at one point in innovations as a periodic service.
In addition to
Being a day service within the CAP waiver. And those are, the blended service, from my experience, worked rather well in some settings. The challenge was around rates and setting different parameters, to be completely honest.
And that's still
And that's something that we have not even, scratched the surface on that piece.
And so, and I promised them the money guy, and Roger was going to come today, and he had some personal conflicts, so he'll be here in, when he's not in there, in like 2 weeks, I think. So as far as like rates and rate setting and how that's kind of structured and what we think about, we will have somebody here for you. We just couldn't get him in today.
And your reason it didn't go further back then?
He probably knows Roger, frankly.
Yeah. It was money, you think?
Roger knows everything.
And well, and one thing too, I just realized we missed this in our Choose Where I Live. Also proposed to y'all, in addition to integrated supports, has been supervised or supported living. So we've proposed 2 different definitions. This service, integrated supports, would be a periodic service that would be blended, and it would be provided when the person's living with family members. Supported living would be a service that they would receive in their own home. And the difference and the distinction is that the person receiving services would hold the lease or own the home instead of living with a family member. So that's another thing that we proposed with regard to Choose Where I Live.
Supported living?
Yeah, supported living is what we call it. There is a slide about it? Okay.
But one of the positive things I think we've gotten as far as feedback from our local stakeholder groups is, like it says in this slide, that it better mirrors the natural flow of the individual's day. So if you think about it, if somebody, depending upon what their goals are, they're not going to be, the worker who's working with them is not necessarily going to be clocking in and out of services as they are working on one goal. And that's not how we function ourselves. There may be a goal for hand washing, for instance, where they know how to pump the soap, but they need to learn how to lather their hands, for instance. And for those 2 seconds, you're not going to be clocked into personal care, and then for the other 2 seconds, clocked into in-home skill building. So by having a more blended service, it allows for that natural flow where you can flip-flop back and forth between supervision and assistance and teaching and skill building. Any questions or comments? Yes, ma'am.
This is for both family-related staff and unrelated staff, and is anybody thinking about the difference for children versus adults?
We are definitely thinking about the difference between children and adults. The care coordinators that I supervise, we specialize in working with children. So I'm always the voice during our committee speaking up and saying, what about children? What about children? And that is something that we're definitely ensuring that this can be, not only this service, but any service can be or is appropriate for children and adults. We've not gotten into the details as far as rates, like we discussed before. We've not gotten into the details as far as should these services be self-directed or agency-directed. And we've not gotten into the details of should these services be able to be delivered by somebody who is a relative as provider. So this is, again, should have been done in June. But, like we said, you live and learn, and we're moving forward. Any other questions before we move on? Thanks.
You haven't proposed anything regarding residential support yet. Currently, the service is provided in alternative family living placements. It's also provided in 3 to 6 bed group homes, depending on where the person is living. And our proposed definition is based on the feedback that y'all provide. I know that throughout the listening sessions, a number of things that were mentioned about residential supports was the need for some way to provide respite for AFLs and how that should be clarified, because it's different from CAP compared to innovations, and it's been a real challenge in some circumstances. Are there any other thoughts about residential supports?
My concern with residential supports and the whole premise of choosing where you live is that your choices are drastically limited by the fact that Cardinal is not offering alternative living situations by the fact that they're not giving out letters to new operators. So the choice is really kind of not a choice. It's a choice of what's already been authorized, as opposed to alternatives which may be much more desirable but have been foreclosed because of the lack of new people on the scene.
So it's a provider network. So
They're not issuing a letter of support for our 5600C license. That's the issue, which is different than the waiver.
Right,
But we can, capacity issue.
Capacity issue, and I think that's going to vary from MCO to MCO. Some MCOs may have providers that have vacancies, so it's understandable that they may prefer to utilize what they have versus opening up a brand new group home. And again, I really can't speak to what each MCO is doing. But that's a capacity issue, and it sounds like it's a network.
It's something I wrote down for perhaps another group, another meeting.
Working on home and community-based service standards where that.
Well, capacity and the quality of the capacity is certainly another good topic. So we'll write that down for an agenda item.
That's a very good point to bring up. Thank you. Any other comments about residential supports?
I don't know that the current service definition says anything about requiring a discharge plan. Is that part of the current service definition, or is discharge planning only if you're in an actual ICFMR license?
Yeah.
And by discharge, do you mean, I'm assuming discharge
Because my understanding is if you're in an ICFMR, like let's pretend you're at Murdoch, one of the first things that they're supposed to do is write a discharge plan and identify the barriers as to why you're not in a community setting or in your own home. And so that's part of the whole planning process is to determine if you can be stepped down, stepped back. So is discharge planning not a part of the residential support service definition?
The residential supports definition doesn't have any information about discharge planning, to my knowledge. It's tied to the idea, because we use residential supports both in community settings like
Right.
alternative family living.
Right.
And even the 6-bed homes where residential supports is used, those are considered community
Right.
settings also because they're not ICF IIDs.
Right.
I'm going to go off of that for a second and just, this is an overarching thing. It's a problem that I see a lot with school systems, and I know education is something that's going to be talked about, and it's not strictly related to school systems. What I mean is transition should be really built into pretty much anything we're talking about. And, you know, I don't care if you're talking about a residential support, a vocational support, whatever type of support you're talking about, there ought to be things built into the service definition to allow for transition to other types of services if it's appropriate. Because lack of transition and lack of preparedness in general is such a huge problem.
And some of that can be built, I'm assuming can be built into the waiver in general, instead of each individualized service, because I think as human beings, we're constantly transitioning. We go through different ages and stages at all times. But you're exactly right. When you have a child, you know, transitioning in school, elementary, middle, high school, and then what happens after that. A transition simple as transitioning from one provider agency to another provider agency, a transition of moving geographically from one location to the next. So we're constantly, everybody's faced with some sort of transition. And that goes back to the involvement of the different members of the treatment team and ensuring that everybody's on the same page. But that's something that could be an overarching
And there is transitional services within the waiver.
Right, there are transitional services.
And those can be used by persons that are in ICF IIDs or persons that are moving out of residential support settings that are not alternative family living arrangements.
I guess my point is I would just say beef that up in general. Part of the waiver.
That's a philosophy thing that we need to start emphasizing more and more throughout the state.
I'm representing brain injury, and that will be a kind of unique transition from the acute hospital to whatever setting someone's going to. And planning is absolutely critical for that phase.
Correct.
So, for good transition.
Good
point. Yeah, and I think like Jessica said, it's definitely a philosophical discussion, but something that needs to be enhanced across the state, regardless of the age or population.
Well, and the other problem with that is you could have an 18-year-old who's almost an adult, you know, who's suddenly impacted.
Right.
And that presents a whole new set of issues and service delivery.
So one more philosophical comment, just because I haven't heard us talk about it in any of the groups that I've been in, and we need to talk about it, is the whole integrated care and medical needs and how are we meeting medical needs, doing a better job of that. So I think that's got to be a big philosophical conversation, not sort of, again, but this one especially, when there's 24/7.
24/7 care and intense medical needs too. Because if we do a better job of addressing the intense behavioral needs than we do the intense medical needs.
Very true.
Just something to mention, so like in the Connecticut Home and Community-Based Waiver, they have a service that is called healthcare coordination that does that across all services for people that are medically fragile. So the person's role, and it may be like an RN or something, does that across all settings for people who have tracheotomies or have G-tubes, those kinds of things, so that they're making sure that occurs appropriately across all those settings, addition to medication administration, those kind of things. That's not a current
No,
service
it's
available
something
in
that
our
we're
area.
kind of looking at when we talk about Medicaid reform in general and where we're going to go for the ACO. That has come up as part of that conversation. But yeah, I don't know how you would, unless you, that would be more of a conversation from the community guide care coordination.
Well, it would be a service in that same sort of vein
Right.
as the community guide. It's much more specialized, obviously. It's probably at least an RN level person, right, that would do it.
We're doing a little bit of that in Smoky because we've been hiring some RN care coordinators for medically fragile persons on the waiver.
Excellent.
To help coordinate and address the healthcare needs. So I think the whole system's moving in that direction because expectation and requirements from Washington are going to expect us to.
And aging, I mean, combining it with folks still receiving a lot of
Exactly.
services that are aging.
And so you can put it on the admin side, right, where the LMEMCO does that as part of care, or you can put it in the service side, where it's a service the consumer family person chooses to purchase with their individual budget.
Exactly.
There may be differences in the way that rolls out, depending on which one of those places you place that. And so if I'm purchasing that for my family member, there's a different goal than if I'm just getting the standard of care, which I agree should be there as well. The standard of care for medically fragile should maybe be a nurse care coordinator, right? So they understand all those medical things for medically fragile folks, but that are real needs. Maybe that should be the standard of care on the care coordination side, which costs more than the current PMP probably allows.
But, depending on how we structure, I mean, you can purchase it, I mean.
Yeah, if you can purchase it, it's just part of it. In Connecticut, it's a service you can purchase with your individual budget.
Okay.
So it's in the actual array in Connecticut.
Okay.
But, you got, so even, say again?
I just said, it seems to me it has to be a core service, because even with the stable folks in our system, there's some pretty significant medical needs that are being dealt with every day. So I don't know that you could necessarily ask families to assume that that would be a purchasable service without denying our responsibility to provide that.
I think that would be a real problem if they can't afford to purchase it and they need it.
Right,
No,
out of the
no,
budget.
when I'm saying with their individual budgets, I'm talking about the resource allocation
Okay,
model.
okay.
So within their allocated innovations waiver slot, I'm not saying buy it out of their own pocket.
Right.
Right.
That's not what I meant by individual
No.
I mean, I
budget.
think there has to be a minimum standard of care
Right.
that we.
It may need to be both places,
Right.
certainly.
Right.
But, so if you think about a family with a child with medically fragile issues, may really want to have someone help with healthcare coordination, to help navigate the medical system, because it's a real big animal, to know that there's all kinds of different G-tubes you can get. It doesn't have to be the Foley G-tube, it can be a Mickey G-tube, and that's a really big difference in the quality of life a person's going to have depending on which one of those they get. In some hospitals, the standard is a Foley, and in some hospitals, the standard is a Mickey. And if you don't know the difference with that, that's the reason you need to be able to purchase the service of healthcare coordination, because it is a quality of life issue depending on which one of those feeding tubes you get. So that's the point I'm trying to make, and generally, people don't know the difference between those two types of feeding tubes.
And then it could also be somebody, I would assume, too, to help talk with physicians, talk with the nurses, to understand all that medical jargon, to answer questions that the family may be a little bit too intimidated to ask during the actual appointment, and then to also help educate the family on, when he said this is what he was meaning in layman's terms.
That's
And next time you go, make sure you ask X, Y, and Z.
Really helps navigate that.
So like with regard to the residential supports definition, would that be a distinct separate service, or would it be something that you would include in the rates? If the
Now, I'm
person had
suggesting
medical
it as a
fragility?
totally separate service, has nothing to do.
Okay.
It might be a part of choose where I live, because if you could get better healthcare coordination, you might not end up in higher levels of care.
Yeah, that's very true.
Right? And so, because your family might be a little more empowered to manage some of that at home than to have you place.
But I would say you need to be able to add it on to residential support, because
Yeah.
there's some folks who are gonna need
Yeah.
In that setting, they might need it as well.
True.
But it would be an augment to that, not
It wouldn't have to
embedded
be
within it.
encompassed,
Yeah,
embedded
right.
within, just something you could add and use with residential.
More than what's already in there.
Or any other service.
Yeah.
Be able to add it on to any other service.
Yes, exactly.
Yeah, it's not an exclusion, but an inhibition.
Excellent. That's
You know, it sort of begs the question that we're having this conversation in isolation. Because with children with Medicaid, there should be care coordination as part of their Medicaid service through their through their medical provider. It's not well done in North Carolina, and it's not very well dispersed. But there is an expectation that the Community Care of North Carolina provide that level of care for Medicaid children. So I think that we might need to have a conversation as to linkages at that point.
And I think most of the children that are on innovations waiver are deferred by Community Care of North Carolina because their services are coordinated by the LMEMCO. So they're not actually in that care coordination pool.
Yeah,
for
and there is
CC.
a cool thing that I think it's the DD Council who's not here today.
Conveniently.
They have a grant that they're doing. I think they're doing it. So they're doing it in Smoky and ECBH, I think, where they have like a navigator. They're calling
Well,
to do it.
we're at the very beginning, let's talk about it phase of that.
Yeah.
But
There's
theory,
a pilot of what I think kind of what you're talking about is going on. I don't know if you want to talk about that at all, or
we haven't piloted anything yet. We're in the let's
so
talk
there's
about
discussion
phase.
of a pilot.
I don't even know that it's, I mean, from my understanding, it's even that. I would say that it's what they're saying is,
Well,
this is what's needed, basically, and they've done a good job of
they're going to
getting the
review
data to
And
see.
defining
exactly
it, I think.
what's
I did
needed.
sit for a presentation on that,
You're
which I thought
fixing
was
to-
good,
yeah,
so.
and trying to inform
Fixing to.
implementation of something.
Nowhere near.
You guys.
But the model that they had presented and the research they had done behind it, I think speaks a lot to what you're speaking of. So, you know, there's some groundwork that's already been laid for that, I guess was really kind of my point.
So then where do you put it? I mean, that's not this room and certainly not my call to make, but I don't know that I would hold off and wait on Medicaid reform when we
Yeah.
gotta submit this and, you know.
Right, yeah. Well, so I think that there's two levels of what you're speaking of. There's this population and then the larger population of people that don't have, anything to do with IDD, but still would need that kind of navigator. Yeah.
Correct.
But I'm anything to do with innovations waiver. Because the healthcare coordinator wouldn't be available to anybody not on the innovations waiver. I'm just suggesting it as maybe a potentially a new service to consider.
Right.
So it was less about where we are on the slide presentation and more about just, since we were having the healthcare conversation, you know, since Carrie took us off task, I just decided to take us off task. Propose that one, because it's a really good one for people with medical issues.
I wrote that down.
We got it on the whiteboard as well.
Maybe you said hard, sir? Give you a hard time with your spelling.
Oh, no.
Oh, wait, let me get a close-up. No.
So residential, the thing I'd like to say about residential support is what's in the waiver is great. I think it works pretty well. I realize that covers AFLs, but I'm not sure it covers companion living, which is a little different because that's when it's, and maybe that's your supported thing that was on the other side, I'm not sure. But so when I own my own apartment and I need a live-in caregiver, or I rent my own place, or I want to live with someone else, but we need a little bit of support, but it's not the same as residential support.
Yeah, and that's one that we've talked about quite a bit, the supported living.
Which I think is maybe the next slide.
Maybe
Community transition is what that meant.
And I want to talk about that.
But support living,
capture that.
Yeah.
correct. We can go ahead and go to the next slide if everybody is good with residential supports for now.
Mm-hmm.
So next is community transition, and Jesse touched on this briefly, and this kind of is back to your question about what sort of transitional planning is involved. And with this service, this supports individuals to be able to transition from a provider-operated home to a home of their own. And here, we've not received any feedback from you guys as of yet, because you guys haven't discussed it.
And I also, like, when I said something about this, I misspoke, because an AFL is a provider-operated home, and a person could move out of an operated, or an AFL using this service.
And I don't know if this may not be one that gets a whole lot of feedback.
Because it's
Although
one that
Ms.
everyone
Short has,
likes.
we're relaxed today, Ms. Short, because it's hot in here. So.
Isn't it a one-time use service also?
It is a one-time setup.
Well, that's not fair.
Once in the person's
Well, I
lifetime,
think it's
that
once in a
affects
waiver. I don't think we do it once in a lifetime. I don't think anything in our waiver is once in a lifetime.
It's a
me. I think it's
lifetime.
a lifetime.
It's a
It
lifetime.
doesn't say lifetime.
5,000 per beneficiary.
But does it mean a lifetime?
So once in a lifetime, so you can move
Lifetime
once.
of the person.
Well, now, let's stop and think about what it is, though. It's about finding some setup charges for a home of their own, some furnishings and things like that. So, yeah, I've never moved in my life, have you? But yeah, you see, that's something we probably should revisit. So there's some feedback.
Yeah, that is a major red flag.
I mean, maybe the lifetime of the waiver, which would make it every 5
Yeah.
years, like
Yeah.
some of the other services are. But I mean, the individual budget, I mean, why would you care? If they're choosing what they're choosing, why would you have limited?
Serious.
That's right. You can have it every year.
Thank you.
Well, is this one an add-on service?
It is an
I
add-on.
think it's an add-on, so.
But that's kind of the point of a flexible budget. I mean,
Yeah.
if that is how you want to do it, then.
Yeah, I mean, if the whole crux of what we're trying to do is make the budgets individualized and flexible, then having any service be capitated on the lifetime of the individual seems to fly in the face of that to me.
I think the one thing that would be important, Cindy, is education in this piece.
Yes.
You know, so that when people are making that decision, they really realize what
You're not
that
gonna get-
means.
You're not going to get this many hours of some periodic service.
Mhm.
And if it's not, it is right now considered, and it is an add-on.
So maybe there should be some kind of
But you
education.
could add, we can decide what is and isn't an add-on.
Yes,
Yeah.
ma'am.
Maybe it's a one outside, an add-on, but then each another time it's part of your budget.
Yeah.
That's an excellent idea.
That's a good idea.
Because it is clear.
Right, so
Yeah.
one time it doesn't count, the second time it does. So, but yeah,
Nothing's free, let me tell you what.
that's a good way, that's a really good way to look at it.
Uh-huh. That and life of the waiver, but life of the waiver then kind of ties your hands.
I mean, I'm not for like the way one.
Yeah.
Okay.
Every year, their budget every year, it's for you.
So we got some feedback on that
Yeah, good.
transition definition.
How strong.
And the next service we have is respite, and this is a service that is intended to provide relief to primary caregivers. One thought that we actually have received feedback on, not necessarily about respite itself, but it is back to what Justin said earlier about residential supports, being able to have some sort of respite that can be used by an individual who's receiving residential support. That's more about the residential support definition, not respite as a service definition in and of itself, but any feedback, questions that anybody has, we're definitely open to hearing.
So I just have one thing I wanted to say about respite, is so respite often gets perceived in the service delivery as you come to my house and we sit there, at least this is my experience in East North Carolina. You come to my house and we sit there while my caregivers leave and go do their thing. And I do whatever I do, but we're not debilitating, we're not doing any of that. In some states, they actually offer that as a recreational respite. So, hey, my mom and dad are going out for dinner, great, a movie, and so are we, right? Because why can't we? It's respite, it's not treatment, it's not habilitation, it's not any of that hoo-ha. And it's now actually something my parents have to feel guilty about doing, because I get to stay home and be bored. Because I'm actually recreating in that. Why do we care? It's respite. But we don't pitch it that way, so
a lot of, and I've heard this from our network at ECBH, that nobody, who wants to provide that? It's kind of boring. You're not even working on any goals or anything. And so the rate's the same. Why does it matter? And it's really about the way it's perceived and conceptualized. And so if, maybe you put a modifier on it, so you know how much of it is the regular old boring thing and how much of it is actually this new or exciting way to spend it. Just asking. It would really be a different approach for people if it was a recreational thing. And even if you think about, so my mom and dad went out tonight, your mom and dad went out tonight, or Carrie's mom and dad went out tonight. Hey, we could go to a movie together. We're friends. We know each other. Now that's group respite. And Mike over there is supervising us sitting at the back of the theater, and we're in the middle, just being two girls at the movie, not having to have all that stigma and crap associated with us. Because we're just two girls at the movie. Nobody even knows we have to work her there. But we got to have some supervision because maybe other people would bother us. That's respite group, and it's more economical. And so when I'm under that individualized budget, I want an economical service to buy, and respite group would be it, right? So just a different way of thinking for people, and an option, right?
Yeah, so reframing it to where it's not just about the caregiver. Is really what you're saying.
You got to have fun while I get respite.
Yeah,
But the rate is not the same.
The respite group wouldn't be for the people delivering it, but it's way more meaningful for me getting it.
I'm definitely on board with that.
Same as what? What were you saying?
The rate is the same if you do recreational respite or regular boring respite. It's respite. It's the way
I
it's
see, okay,
positioned.
I'd like to see that in the title. Regular boring respite.
You guys. Go back to the way in which it is being presented to the family, to the individual, as well as to the provider agencies. And I can speak to the team that I supervise, and it actually is being presented the way in which you just described. And we tell families that, while it's not a habilitative service, unless you're sitting like a lump on a log on the couch, you are actually working on goals, because you are going to have them look both ways before crossing the street when you go out into the community. You are going to have them, you are going to go out into the community. You are going to have them work on tying their shoes, washing their hands, putting on their jacket before they go outside and so forth. So you work on goals in a kind of happenstance manner. Right. But it's, again, I think it goes back to the way in which it's presented, the way in which it's perceived.
Well, it's going to be the way you write it, too. So,
The way the definition
Right.
But I don't even know if we need to modify if the rate's the same.
No, you don't have
Put
to
in
have
the
a
definition. That, well, no, I mean, I was just thinking that through. I don't know.
Yeah,
I
I think
need
you
a
just
modifier.
add those ideas
Yeah.
into
You could do, these are some of the things you could do with it.
Just write in the definition.
So when you look at the current definitions,
Yeah.
boring.
Yeah, the definition's written around the caregiver and just giving them a break. And you could add some language into the definition about support and supervision for the person to engage in activities in the community. Right now, that occurs somewhat with personal care, but not as much as it could. And personal care, if we were to blend, would kind of go away. And you don't want to have to, a person shouldn't have to be trained to do things like go to the movies.
I mean, it's really interesting to me because I do know, and what Jamie says is true, there are some great providers that aren't maybe worried about audits, but there are some providers in our network that wouldn't do a movie because we have pounded them over the head that you don't go to movies with Medicaid dollars.
I've heard of it.
In other services. And so you've got to be real, some people would just say, hey, now I'm at PCG in my
house.
house.
I want to go back to a
The news and
community
observer
support
about
kind of a
that,
thing. That's a true story, but.
That's right. So we just need to, if it's clear and it's allowable, then it's,
Yeah, for this
maybe that
service.
makes it a better service, one that's a little more attractive to people.
All right, so we're going to have to tell Mary she can't come back.
Yeah. I want to hear 2 meetings.
Yeah.
As a second.
I have a few thoughts. First of all, I want to echo a lot of that. I see, like, I fancy myself as having a pretty decent understanding of what the waiver is capable of, providing, or at least, a good general idea. But even when I see, the word respite, and I think about what I consider the service to be, I can guarantee you where my brain goes when I see the word respite is nowhere near the scope of what, it's able to reach. And again, that's a community education thing. And also, like you said, writing something into the definition that says, the service is a little bit more flexible than this, and, here are some examples of some other things that you can do. But the other thing that I wanted to emphasize is I know from, not necessarily from personal experience, but I know from other people that providers are very hesitant a lot of the time to go out and do things out in the community because they don't think that it fits with a service definition. And that, to me, is really, really frustrating because it's like, what are we doing here if not trying to create an environment where that's not something scary for the provider, you know what I mean? And the fact that it is scary for the providers means that it doesn't happen for the recipients of services. And that's a big problem. And I see it all across the spectrum, all across different ranges of services, and just everywhere. So.
If they're not going out to the community, what are they doing? Or what have you seen?
Well, I've just heard examples of, like, thank you. Somebody used the example of a provider saying, well, we don't want to. We're not going to go. We're not going to go out to the movie because that's not that doesn't fit this definition. That, yeah, exactly. And I've literally heard parents tell me about their children who admittedly need more supervision than someone like, say, me, for example. But I literally have heard parents tell me stories of providers from a group home refusing to allow an individual to go out to a movie or out to dinner because it didn't fit within, service definitions or hours or programs or whatever the heck excuse they were trying to use. And we're talking about adults here. Granted, we're talking about adults with, developmental disabilities, but we're talking about adults here. And they're being treated like children. And I just think that it's wildly inappropriate. And I understand that part of it is fear of repercussions from the providers. But I also think, and I'm going to come out and say this, I also think part of it is convenience for the providers. For some providers. I'll be more diplomatic.
And so maybe one thing we should have said at the beginning and kind of put an emphasis in big bold letters, and this has been the one term that we have used quite frequently in our meetings, is we want this waiver to be more flexible. And so that is our goal here, is to provide kind of the guidance and the structure through the service definitions, yet at the same time provide flexibility too. And that's a little difficult because you're almost talking about two opposite sides of the coin almost. But
clarity.
Right, so to provide
Right,
to provide clarity, and when you have words on a piece of paper that are black and white, that's essentially what they are, is words on a piece of paper, and so how I interpret it may be different from the way in which you interpret. So providing that structure and that guidance and that clarification, yet having flexibility at the same time. Yes, ma'am. And then I think actually you had a question.
I wanted to add to this gentleman's comment. I mean, he said convenience, but I think it's money. I think that the reason some of the group homes do not go out in the community is because it costs money and it comes off of their profit. Whereas if they just do something that's sedentary or free, then they get more money. So the way I view respite is anything that's not in-home skill building. So if in-home skill building had kind of a more defined or more specific definition, then it could state, well, respite is activities in the home and community that do not include in-home skill building. So it would, and then you don't have to specify that it's specifically recreational or whatever. Because if you have a more, and then also it gives guidance to the people that are doing in-home skill building, what the hell they should be doing at that higher rate of pay. Because a lot of times they get in-home skill building and they just take everyone out in the community and have a good time rather than actually working on skills that the residents need to make them more independent. So I think the emphasis really should be on a better definition of in-home skill building and then let everyone know that respite is everything but that. And also my other concern for respite is that the nighttime hours, respite's at a lower rate of pay, and it's a lot harder to get people to do respite unless they tack it on with in-home skill building. And so if the caregiver wants to go away overnight, then there's a big difficulty trying to get people to spend the night. I don't know if there could be any sort of like respite location where people could go with just the opportunity to spend the night, which would be obviously cheaper than if, or there could be a certain, increased rate for nighttime if it's used within, you have like a week of it per year.
It's offered now with a modifier for overnight, right? Or periodic. Isn't it?
It's offered, but the rate is low and nobody wants to do it.
So it's just periodic. Yeah, because on the state side, you have not PMA, but on the state funded services, you can get overnight respite.
Well, and we'll talk about that more when Roger comes too, about like how, because we're gonna have to talk about that a little bit.
Two things we're going to have to do. One is that we're just now, again, collecting all of the data from the last state fiscal year to kind of start getting a full picture of spending and an idea of what our model is actually going to look like, so what our budgets may actually look like based on actual hard data as opposed to conceptual.
Right.
Al, I'm sorry? She's
No,
not in. She's not in here. And when Roger comes and speaks to us about rate setting, both for the overall waiver and budget neutrality of the waiver, as well as how we set individual rate definitions or rate models, which of course you're not limited to as MCOs, but I think all y'all kind of use it as a basis, at least for now, which makes sense as we're in early days. I think that's going to be a pertinent part of this conversation.
Well, and then the individual person has the ability to be flexible within their rate, within their individual budget with their rates.
Sure.
Except that dips into how much money you have available to buy services if you raise the rates.
If I buy a Mustang, I've got to eat ramen, I mean. So do you want to go on to support? Are we good with supportive living? Are we done with respite? Ready to go on supportive living?
The only thing I wanted to say, as a provider, some of the things we run into with providing respite is, say, for instance, we have somebody that's allotted a certain amount of hours per week, and they use all those hours Monday through Friday with in-home skill building, community networking. Well, the mother works every Saturday, so she wants to use the respite scheduled every Saturday to cover her work hours. It's getting the families to understand really what the purpose of respite is, and it's not to cover her work, it's for her to have a break from her care. That's usually what we run into, is things like that. Parents wanting to pad the services that they already have at times.
So when you think of that as support structure, the research around respite is you should use it early in your role as a caregiver and often. And it should be one of the least restrictive services to use that is available in any array. Because it is the service that allows everybody to continue to live where they are. That's what the research shows about respite. And so,
and for people to stay married.
Not to have it something that you
It's the truth.
You only ask for when you're at the 11th hour of death in the caregiver role. And now finally you'll just break down and ask for it. It shouldn't be something people are made to feel guilty over, that they shouldn't use. I mean, it really, the research proves that this is the service that keeps families together. And so I just have to say that I wouldn't sleep tonight because it isn't structured in any of the systems in North Carolina today to be that for families.
But
it makes a big difference. It makes a big difference in that structure.
On the positive side, it's the number one thing B3 dollars are being spent on.
That's right. Absolutely is. It's so needed.
The number one
The
thing is the B3 dollars. We discussed, I don't know if y'all remember that conversation about it coming out of the savings to B3 dollars, but that is the number one thing that we're spending it on, is respite.
Additional respite.
No, you don't get to, you're late.
You're
cut off.
Well, I did come in late to the discussion, so you may have covered it, but respite is, for as long as, back when I was with the division many years ago, was the number one requested service. And has remained the service that parents and families ask for the most. It is a low rate of pay. Providers are not motivated to do it in some circumstances. You know, it's great to have that kind of flexible use, but it's hard to find staff that want to work for the lowest rate that we have. And, but also, I came in on the piece on flexibility, and we talked about that before a little bit. Providers are very into providing flexible services that meet each individual's need. In group settings, well, in every setting, there's a positive correlation between the level of flexibility and the amount of funding. We would have everybody be able to do everything they would like to do if there was funding enough to accommodate the level of supervision and staff required for that flexibility. Sometimes that's not possible within the budgets, and I guess with individual budgets, as we move there, I think people get a better concept of this is what money I have, and this is where I might like to spend my money, and what trip I might like to go on, or et cetera.
Or maybe what the rest of it needs to be done in conjunction with, and that's why I keep deferring back to rate setting, because I think that's an important piece of this. I mean, rates are low, but when you're figuring out rate structures, what are the qualifications of the people that are doing these things? What exactly are the tasks that they're supposed to be doing, and how do you figure out what that I mean, and we'll talk about that more in depth, but you know, if you have somebody with a high school diploma, that's going to pay differently than somebody that's like a psychologist. If you spend more money on the respite, what does that take away from other places in the budget? So it's a puzzle.
So we're going to move on from respite.
I think we're going to move on from respite.
So the supported living file or slide that I said was not there. It's there. So when you say we don't have a current one, but we do have a proposed one. And this really, it's supposed to mirror the natural flow of a person's day in their own home or apartment. So, and that's the whole basis, is that it's the person's home or apartment. We're starting with the person's home first, so that when a provider burns out, they don't have to move. Someone else can be located to provide this service. This is going to be really impacted by what we choose to do with rates too, because it's almost would be, in some circumstances, impossible to do this within the constraints of our existing rate. But it's definitely something that we need and is considered a better practice. And we have a really good start on this definition. And we've looked at places like Wisconsin, Tennessee, other states that are using this service effectively. And we have the advantage, I know our legislators, two people are renting their own home, you don't have to license or do those pieces anymore either, so that will help providers ultimately too. So, any other ideas about this service?
Jesse, I've got a question. When you've looked at the other states, have you looked at their rates? And then
yes.
times 365, and
yes. And
is
they
it within
get really
130?
high.
Is it within a waiver?
Like, to support a one-person home is roughly about $168,000.
So
if you're going to staff the home 24/7. And that's what you'll see in Tennessee. And Tennessee's got a really elaborate rate structure set up.
And I think they have 5. They do this definition based on levels. They have levels 1 through 5, and the rates are rated.
And it's also impacted by the number of people that are living in the home. So, you know, you don't want to really exceed 3 people in the home. But you can cut certain hours in half if you've got 2 people in the home, because you just need 1 staff overnight sometimes. And of course, technology is impacting this too, because there's ways that you can monitor homes, because not everyone needs a person awake overnight. I know that some providers that have done this looked at group homes and the place that there's, why do you have an awake staff overnight? Because a lot of the times you don't need one, because there's no real necessary, nothing happens at night in some places. So this is, to me, this is the most exciting thing we're talking about.
I just wanted to mention that this is a service definition that really was initiated by families of individuals that live in our developmental centers that really wanted to look at something different. They wanted their adult family member to live in the community in their own home. And the rate setting part of it will probably be a little bit complex, but it's the direction that I think folks would like to see us go, and that is very much needed.
Yeah. And you know, I think some of that came from families trying to move folks out of institutional settings because they see what happens in other settings when a person goes in crisis, and it's the provider-owned home and AFL. You're spending 60 days looking for another AFL sometimes, and the person's just really jumping from home to home. But if we're wrapping the staff around the person in their own home, and we start utilizing other public fundings such as, you know, Section 8 vouchers and other things, the person will have more of their own money to pay to do some of the activities in the community that they currently don't really get the opportunity to.
I might also comment on some data with the National Core Indicator data that shows, generally speaking, outcomes are higher for folks that aren't going to have to move if something happens between the provider and that individual. So there's more continuity that lends itself to generally a higher achieved set of outcomes. And that's been collected and analyzed. And it was just presented at the National USED, which is the University Center on Excellence in Disabilities Conference.
Just on, as a part of the stakeholder engagement group, the principles that you're discussing are exactly the kinds of things that were being embraced and endorsed in that process. So,
yeah, I've seen those 5 goals, and it's a place to live, a place to work. It's not dependent on everyone else but me.
This is very needed.
Yeah, I did. I was just going to say, going off of some of what you were saying, I think, and granted, this is only in certain circumstances, but I think with certain individuals, if you could properly combine supported living and assistive technology, you'd be looking at pretty much the holy grail of what everybody's looking for, which is a person or a couple of people being able to live, you know, independently in their own home while not needing, you know, a really overblown price tag and them still getting everything that they need. Just using myself as an example, if I was to live in my own home or apartment, and I know this because I lived in the dorms at college for a while, I would only need support other than previously arranged personal care, which is, you know, a certain number of hours a day. I would only need additional support in an absolute emergency. So if I had, you know, the right assistive technology to where if I was getting sick or something and I needed to call somebody and say, listen, I need somebody over here right now because, you know, this is something that's going on that's, you know, an emergency situation, then that's the only time that I would need something like that. I wouldn't need an overnight staff or even staff that's there more than the couple hours a day here, couple hours a day there. And granted, I'm a fairly unique instance, but I think that there are a lot of people that at least fall in the same general category as I do. And I understand the fear of, well, what if something happens overnight in that person? But with utilizing assistive technology, you could eliminate so much of that, and I've heard of it happen, and I've seen it happen as well with some people that I know who do live in their own apartments with some assistive technology as well. So I think that 1-2 punch is a really, I'm not going to say it's a magic bullet because it's not, but I think it would be a really big step towards
And even in homes where people would need more supervision and support, assistive technology, if we continue to move in that direction, certainly can allow lower numbers of staff support if we're innovative in how we do it, and response times based on individuals that live in that setting's need, their need to live in different homes. Also on supported living, I guess, the fact that this would be a kind of a bundled service, blended service, better said, with kind of our current habilitative type service, in combination with personal care service, definitely has rate implications when you do that. That does have an impact on things. It does have an impact on the quality of staff that we can get. I know that, I guess there's some data that I understand from MCOs that lots of people that provide our current habilitative services, it's the same person that provides personal support. I think sometimes it is, sometimes it isn't, but one of the things that habilitative and having people that are have a GED and have the ability to read and write well and can write a note, those are harder people to find, they're harder people to keep, and you have to grade them a little bit more. Parents, families have seemed to like those staff because, this is one of the funding dilemmas that we're in. If you have people that are better paid, they're happier with their jobs, typically, and they stay for a longer period of time. And really what one of the great things about is the relationship between the individual and their support person, and having that relationship over a period of time. So there are rate issues involved with this. If we move forward in this, I think everybody, for the most part, is interested in the type of service that we provide as far as more of a natural flow for their day. But there are other hurdles with doing that we're going to have to resolve.
For sure.
I think this will provide a lot more stability. Working with AFL homes, that we've got consumers in our catchment area that go from home to home to home at times, and I think them being able to be in their own home and have rotating staff that gets a break, and it would decrease the amount of crises, of course, and then they wouldn't have to be flipping provider after provider. So
And if something
this
were
is
to
well
occur to
needed.
the staff and the individual, then it's the staff who leaves, not the
Yes.
individual, which is the
Yeah, and you
premise.
can have the video monitoring and all. This is great. I mean,
Yes, ma'am.
With regard to a comment on assistive technology, I know that now they're developing a lot of apps for senior citizen, checking up on senior citizens, and that could be transformed easily to a scenario here, and that's relatively inexpensive. My concern with this definition is it seems to imply that you're a single person living in your own home, whereas I think it would, I don't really see that as a positive necessarily, being isolated in a home with a staff person, whereas if the definition didn't use the word own home, but maybe privately funded home, I think the concept of having 2 or 3 people not only diminishes the cost, but it lends itself more to a communal or family scenario as opposed to someone living in isolation. And it seems to preclude people who don't live in that home, because the word, I actually don't like the wording of this at all, but it seems to preclude people who don't live in that home from joining that home as a roommate.
So keep in mind, this is just a brief description.
This is a statement where we're trying to get the idea across that the
Yeah,
home
it's
is the
something to
person.
think about
And
when
it could be a roommate situation, and I
But
think
that
the
doesn't
definition.
imply that.
Yeah, well,
It stresses
the
own
definition
home.
does, this slide doesn't really
Okay.
well. I agree with you that this slide doesn't well.
And
But when you get into the definition, it outlines different, that it could be roommates up to 3 people.
I thought we were working on definitions.
We
But
are
we
working.
have a defective slide that doesn't say the definition.
Well, and
Well-
honestly, the definition is about 3 or 4 pages long. And so this is just, what we look
Yeah,
to
this
do-
is just a statement that's supposed to capture the idea.
Concept.
That's
And
right.
the concept,
Right.
thank you.
And if you recall at the beginning, what we had talked about was we were going to get feedback from you guys, and maybe what would help is if we give our timeline, because all of the feedback that we're going to get from you is not necessarily today and today alone. It's going to be kind of an ongoing process. And so what we've done is we've scattered out the different service definitions to get feedback from you guys, kind of 3 definitions or so at a time. And that way you can, these are just brief snapshots and descriptions, but then once we start to collect the feedback from you, or prior to us collecting the feedback from you, is when you would be given the actual service definition with the meat and potatoes to it, so to speak. Yes, ma'am.
The other piece on that would be, if you have the concern about isolation, you also have the concern about what goes on between whatever provider who might be good, but might also be potentially abusive, or whatever. Where's
So it
the
needs to be
security
monitored.
for those, especially if you have someone with communication?
And I think that could potentially be a concern in all cases with all individuals with Alzheimer's, not just this.
But if it's a larger group, there's more likelihood that people would know.
Would know what was occurring.
Right,
But
No, they cover for each other.
The service definition speaks to this even more eloquently than what this 12 words or so on the screen do, where it talks about it's truly what the individual wants and what the individual needs. I may not want a roommate. Right.
Hello.
And I need to specify whether or not I have a roommate. I may not want staff 24/7. So, and again, the service definition speaks to that.
Right, right. So I'm kind of keeping an eye on the clock. You got a few slides left. The next slide is crisis services, and so you probably want to just sit down for a minute and wipe the brow there. So if we take maybe just 10 minutes and then come back and dive back in.
Before we go, or can we, I have one comment I'd like to make before on this service
And you were,
definition.
okay, sure.
So in the service definition, it was mentioned, it's designed for 3 residents, including the living caregiver. And there's more than just this one committee going on. And there has been discussion in other committees about the magic number 3, whether the magic number should be 4.
This is an unlicensed home though. And the tree is part of the law, or the change of the rule where.
This is always unlicensed.
Yes, it would always be unlicensed. That's why we couldn't go beyond.
Provider, it's in the name of the person.
That's right.
People renting together or whatever.
But still,
It's individually controlled.
So are you suggesting that we consider the number?
well, I don't know, I'm just asking,
They want to be licensed because it's got to be regulated.
To
Well,
reconsider
and
the
yeah,
number would
you
require
did miss
administrative
that kind
action.
of part of the conversation. We're gonna try to have a different conversation about facilities and licensure and provider network and monitoring quality. So actually, that, a little earlier we discussed that, that's another day's topic, if you will.
But this is not licensed. So you want to say
Yeah, this is not licensed, it'd be like my house, and you can move in, although maybe not you.
Straight through that door.
Or are we taking a break?